So what are the complications? So when you have low GFR, what are the complications that happen? So the main kidney functions, okay, which is sodium balance, potassium balance, acid base balance, calcium and phosphate balance, and erythropoiesis. So these are the key functions of your your kidney. All of these start decreasing as you reach kidney stages, CKD stages 3 to 5. Okay. In CKD stages 1 and 2, you do not have any of these complications. So stages 3 to 5 are the stages when all of this goes for a toss. Okay, so these are very, very important. All of this start getting affected by grade 3 to 5. So you have in sodium balance, you start retaining sodium and you start having edema because of volume overload. You can start having hyperkalemia. Hyperkalemia is completely, very variable from person to person, and also variable depending on the disease that you have. Diabetics are more prone for hyperkalemia. The drugs that you take, like ACE inhibitors, ARBs, also can produce hyperkalemia. Overload of potassium. So when you load somebody, say you have a GFR of say 45, unless you take more potassium, you load your kidneys with potassium, you might not develop hyperkalemia compared to somebody who will have, uh, less potassium intake. A person who has more potassium intake in the body can have more hyperkalemia. So hyperkalemia can also develop. Acid base excretion. So metabolic acidosis starts developing by grade 3 to 5. And also you will start seeing hyperphosphatemia, hyperparathyroidism, and decreased serum calcium and decreased calcitriol production. We also saw in the last class that 1-alpha hydroxylase is an enzyme that is being produced by your kidneys in your proximal tubule cells. So when you have early CKD, the 1-alpha hydroxylase starts going down. So your active vitamin D or calcitriol production starts reducing. So all this starts coming by grade 3 of CKD. And also your erythropoiesis. Your erythropoietin hormone is also secreted by your peritubular cells from your kidney. So that also reduces and results in anemia. Okay. So then you will have to treat all of this. So the treatment for CKD also is essentially not bringing down the creatinine, but actually treating the complications. So it will involve sodium restriction and diuretics, dietary restriction of potassium, and avoid drugs which will increase your hyperkalemia, adding soda bicarbonate, phosphate binders, calcium emetics or calcium supplementation, erythropoiesis stimulating agents, and iron replacement. So all of this treatment you'll have to check for the complications, test for it, give additional tests where you might modify the treatment and start treating all of these complications. So moving on to in detail, what are these complications of CKD? So mostly kidney has a lot of endocrine function. The most important of this function is actually one is renin. Renin, as we saw that in the macula densa, you have macula densa, which is at the junction of your afferent arteriole and your distal convoluted tubule. You have the juxtaglomerular apparatus, which has your macula densa, which the cells of which secrete renin based on in the response to the drop in arterial pressure or the increased chloride that is being sensed by your macula densa. The erythropoietin, so that is a very important hormone that is secreted by your afferent arteriolar and your macula densa apparatus. So that is one of the endocrine functions. The other endocrine function, as we discussed, is your erythropoietin. So that is secreted by your modified cortical fibroblasts. These are present around your peritubular region. So erythropoietin is a hormone again secreted by your kidney. The other one is your 1-alpha hydroxylase enzyme that is also present in your proximal tubule cells that converts your native vitamin D to the active form of 125 hydroxy vitamin D. So apart from this, your kidney takes part in net acid excretion by either bicarbonate regeneration or reabsorption. We saw it in the class. And plasma osmolality, which is very important for the solute balance, your aldosterone, your ADH, and your rest of your tubular transport across the entire tubular lumen is all very important for having an appropriate sodium balance. Okay, so as we progress from CKD 1, 2, 3, and 4 and 5, you see the incidence of hypertension increases, the incidence of anemia increases, bone disease increases. If you're a child, the growth failure decreases, and acidosis. If you see CKD 4 and 5, the incidence of acidosis is so high, and also hyperkalemia. Compared to other stages, CKD 4 and 5, significant hyperkalemia, metabolic acidosis, you have what is this, bone disease, anemia, and all of that will be there. Okay. uh, so all of these complications start coming from significantly from your CKD 3 and 4 and 5. Your hypertension alone can be present even in CKD 1 and 2, because we saw that there will be glomerular hyperpermeability and already albuminuria would have started. So hypertension can happen even in early stages of CKD, but your other complications significantly increase when you have CKD stage 3 to 5.